Hello, welcome everyone. Today we will discuss a very important topic, very important question among the chapter of the mineralocorticoid is regulation of aldosterone secretion. Now there are various stimuli which affect the aldosterone secretion, either they increase or they decrease the aldosterone secretion. Some factors also increase the glucocorticoid secretion along with the aldosterone, and some factors are there which only affect the aldosterone secretion but doesn't affect the glucocorticoid secretion. In the first group, the factors which increase the glucocorticoid secretion with increasing the aldosterone secretion, they are any surgery or stress related conditions, anxiety, physical trauma and hemorrhage. And the factor which does not affect the glucocorticoid secretion, they are high potassium intake, low sodium intake, there is constriction of any vena cava, there is standing posture, secondary hyperaldosteronism, and in some cases heart failure, cirrhosis of the liver and the nephrosis. But remember, the main important primary regulatory factors in this context is ACTH from pituitary, number 1. Number 2, renin secretion from the kidney via the help of angiotensin 2. And third one is plasma potassium ion concentration, also has a direct effect on the adrenal cortex. So we will discuss these 3 points one by one in more details. Number 1, effect of the ACTH. Now remember, when we first administered the ACTH into the bloodstream, they increase the output of the aldosterone as well as the glucocorticoids and the sex steroids. But remember, the amount of the ACTH required to increase the aldosterone output from the adrenal cortex is much more than the amount which has the glucocorticoid secretion maximally output into the bloodstream. That means the amount of the ACTH which is required to produce a huge amount of the aldosterone is much more in amount than the amount which is required to increase the glucocorticoid secretion. So you can easily understand, when the aldosterone is increased to its peak level, the glucocorticoid has already achieved that level in its previous conditions. So the effect is transient. The effect of the ACTH is very much transient. Even the ACTH secretion remains increased and the aldosterone output with the help of the increased ACTH secretion decreases within the 1 or 2 days. That means even if the ACTH secretion is much more, the aldosterone output goes lower down within 1 or 2 days. What is that reason? The reason is partly due to the decreased renin secretion, secondary due to expansion of the extracellular fluid volume. But it is possible that some other factors also decreases the conversion of the corticosterone to the aldosterone. So it is very much important why the effect of the ACTH is transient. But remember, even if the aldosterone goes down within 1 to 2 days, the deoxycorticosterone level remains elevated with the help of the ACTH. Now we all know the ACTH comes from the pituitary, mainly from the anterior pituitary. So if we remove the anterior pituitary gland or after hypophyseectomy, what will be happening in the body? So number 1, the basal rate of the aldosterone secretion is normal. Number 1 is a very important point. Number 2, there will be increased aldosterone secretion produced by surgery and other type of stresses. This effect is totally absent. Remember, in the normal cases, as we have seen in the previous page, the increased glucocorticoid secretion or increased aldosterone secretion occurs in response of stress, anxiety and surgery. But in this case, after the removal of the pituitary gland, this response of the increased aldosterone secretion according to the stress is absent. And the third point, the increased aldosterone secretion due to the dietary salt restriction, which is normally happening in the normal person, it persists for some time. So remember, these 3 points are very, very important. And after this salt restriction, the increased aldosterone response, later there will be the zona glomerulosa atrophy, which complicate the picture in long-standing hypopituitarism, and there will be salt loss and hypoaldosteronism. So this effect of increased aldosterone secretion in response to dietary salt restriction is also occurring for the some time. It's also transient, and it is later on develops the salt losing condition and the hypoaldosteronism. So normally glucocorticoid treatment does not suppress the aldosterone secretion, but however, an interesting recently described syndrome is glucocorticoid remediable aldosteronism, or GRA. Remember, in my previous videos I have already talked about the causes of the primary hyperaldosteronism or Conn syndrome. In that case, I mentioned one condition, this GRA or glucocorticoid remediable aldosteronism. What is that? The clinical feature is autosomal dominant disorder. It is an autosomal dominant disorder in which there will be increasing in the aldosterone secretion produced by the ACTH is no longer transient. Normally we know the effect of the ACTH on the increased aldosterone secretion is very much transient, but in this condition of the GRA, the autosomal dominant disorder, this response is never transient, is a permanent. It's not a transient, it is a permanent response. What will be the treatment? The hypersecretion of the aldosterone and thus accompanying hypertension are remedied when ACTH secretion is inhibited by the administering glucocorticoid. So whenever there will be increased ACTH, there will be increased aldosterone in this condition. So to suppress the ACTH secretion, we need to give the glucocorticoid. So they will inhibit the ACTH secretion by the negative feedback effect. So what is the cause of this GRA? It is a genetic cause. The genes encoding the aldosterone synthetase enzyme, you know, the aldosterone synthetase enzyme is a very important for conversion of the corticosterone to 18-hydroxycorticosterone, and the same enzyme is also responsible for the conversion of 18-hydroxycorticosterone to aldosterone. So in nutshell, the aldosterone synthetase enzyme converts corticosterone to the aldosterone. So the genes encoding this enzyme and the 11-beta hydroxylase enzyme are 95% identical and closely located at the chromosome 8. So you know what is the function of the 11-beta hydroxylase. 11-beta hydroxylase on the mineralocorticoid pathway converts 11-deoxycorticosterone to corticosterone. So if these two enzymes are very much identical and in the same locus, in the patients with the GRA there are some unequal crossover. So the 5' regulatory region of the 11-beta hydroxylase gene is fused to the encoding region of the aldosterone synthetase gene. So that's why the product of this hybrid gene is an ACTH sensitive aldosterone synthetase. So whenever the aldosterone synthetase takes action, if there is presence of increased ACTH, it will convert more and more corticosterone to the aldosterone. So effect is never transient, effect is everlasting. Now second point, the effects of the angiotensin 2 and renin or the increased aldosterone synthesis. Now the octapeptide angiotensin 2 is formed in the body from the angiotensin 1, which is liberated by the action of the renin on circulating angiotensinogen. You all know this fact. This renin is coming from the juxtaglomerular cells or juxtaglomerular apparatus, and it converts the angiotensinogen to the angiotensin 1, and from the angiotensin 1 the angiotensin converting enzyme converts the angiotensin 1 to angiotensin 2. Now the injections of the angiotensin 2 stimulates adrenocortical secretion and in small doses also affect primarily the secretion of the aldosterone. Now the sites of the action of the angiotensin 2 are both early and late in the steroid biosynthesis pathway. Remember, the angiotensin 2 has two different modes of action. Number one, the early action is on the conversion of the cholesterol to pregnenolone. Remember, the cholesterol to pregnenolone conversion is done by the enzyme cholesterol desmolase. Okay, and here the angiotensin 2 has a very important effect. And the late action is on the conversion of the corticosterone to the aldosterone. Again, the corticosterone to the aldosterone is converted by the enzyme aldosterone synthase. This aldosterone synthase enzyme takes action with the help of the angiotensin 2. So, angiotensin 2 has two modes of action in the aldosterone biosynthesis pathway. Now, angiotensin 2 does not control the secretion of the deoxycorticosterone and it is only controlled by the ACTH. So, remember, angiotensin 2 has only the effect on the synthesis of the aldosterone, not on the effect of deoxycorticosterone.